Welcome to Make America Healthy Again. Join Dr. Charles Antonori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antonori.
This is the Make America Healthy Again podcast. I'm Dr. Charles Antonori, and the guest today is my partner, Dr. Leon Kushner. He partnered before I retired.
How you doing, everyone?
He's a very great endocrine surgeon and ran the surgical residence program at Inspira when we were there. But Leon, you want to give a little bit of your training and background, that sort of thing?
Sure. I did all my medical training in upstate New York State, and afterwards I did my endocrine surgery fellowship at Mount Sinai in New York City, and I graduated that in 2011, and I came straight to Inspira, and I've practiced at Inspira with you, Charlie, for a little over a decade.
Yeah, I think about 12, 13 years, I think, total. Yeah. Geez. Where'd the time go?
Time flies by when you're having fun, huh?
Yeah. So I said we talk about endocrine surgery, but I think first we'll talk a little bit, since you would have ran the residency program, and there's a lot of interesting things going on with surgical training. We can talk about surgical training first, and then if we have time, we'll get to the endocrine surgery, or do it another time if we don't get to it. Like I say, it's generally 20, 30 minutes we go here. But just thinking about the surgical training, when I went to Dartmouth, and that's where the Flexner Report, I knew about the Flexner Report. Nobody knows about the Flexner Report. It was like there were two Flexners. One worked for the Rockefeller Institute, which was like a big deal in like the early 1900s, in terms of medicine. It was one of the main places. And his brother, I think, did the Flexner Report, where they evaluated all the medical schools. And it was where they first went to, what we consider currently medical schools. And the reason I remember this is that Dartmouth was where I did the first 2 years before I went to Harvard, was one of the medical schools that they sort of closed down the clinical. They made Dartmouth a 2-year school. That's why I had to transfer. Because the Flexner Report said that it was fine for the first 2 years, but it didn't have enough clinical material for the second 2 years, And
so you did your medical school. You finished the medical school at Harvard. You said, correct?
Finished at Harvard. So I did the first. And when I was there, originally practically the whole class transferred from Dartmouth to Harvard, because Harvard had all those hospitals in Boston. Boston City, Peter Ben Brigham, Mass General, Boston Lying In. They had a million Mount Auburn. There were a million different hospitals in Boston that Harvard had. So they had plenty of clinical material. Mm-hmm. And anyway, this was all with they really revamped medical education. Like, you have to remember, like around that time, the disease theory the germ theory of disease was just brand new, and not all doctors even believed in it. It wasn't like till the 1890s and stuff that even started. And then Johns Hopkins was really the place that really started like residency programs in general, and in the modern started basically the modern era of the way we train.
Right, and you were in clinical practice after residency for like 40 years, correct? So this was
after residency about a little over 40 years. Yeah, 40 couple of years, 42 years. Yeah. And so I saw a lot of changes. But anyways, we know like the Halstead was the guy that's considered the father of surgery. He was interesting too in that he was addicted to cocaine. He's like that show, the Nick or whatever it was on TV was, I think, sort of about him, because he did practice in New York, and he did get addicted to cocaine. I've read one thing that said he got off the cocaine by switching to morphine.
Right.
But, yeah.
And also, I remember you telling me about the pyramidal programs, because nowadays, if you get accepted to residency program, you're pretty much, almost guaranteed to kind of finish unless something bad happens.
Unless something bad happens.
Pyramidal programs, correct?
Yeah, when I was training, there were two. When I went through, there were two kinds of programs. There were programs that were not pyramidal. You could go, but like a lot of the better programs, Mass General, Johns Hopkins, Columbia, Cornell, they were all pyramidal. Ours was 12 to 5, and in my year it was actually 12 to 4, because one of the guys that had been pyramided out did research for 2 years, and they were taking him back in.
And that means there's 12 interns in the first year, and then by the time you graduate,
Columbia did it. Some places did it. Some places did it like a couple chipped away, a couple along the way. And that was really bad because then you could get into 2, 3, 4 years and get cut, and that was really made life miserable. But by the time I got around, again, this is the 1970s. I finished medical school in '73, and I finished Columbia in '78, and by that time, most of them had one cut. And the way Columbia did it was they told you at the end of the first year or internship year or PG 1 year, and then you could do a second year of general surgery and then find the subspecialty. So that you had a year, and that's what a lot of people did was and some of the people they took, some of the interns that they took already were signed up to go into urology or orthopedics or something like that. So it wasn't always that there were 12 that wanted to stay in general surgery and only 4 or 5 slots. But
fascinating how different it is nowadays.
Yeah. And so we were talking about how resident training has gotten so much harder in a way, too. Because I only had to learn things one way, open. We just did open surgery. I learned laparoscopic on-the-job training starting in 1990. I was already out like, 13 years? Yeah. So I finished 78, 80. Yeah, I practiced about 10 years and the 7 years of residency before laparoscopic even started. That started like right around 1990 and had to learn that. And then, now we're talking about the robotic is coming in. So the residents have to really learn 3 ways. I only had to learn 1. You learned basically 2. Yeah.
Yeah, and as you mentioned, I mean, the technical aspects of surgery has definitely changed and progressed. I mean, as you said in the past, it was only open approaches, and then transitioned to laparoscopic and minimally invasive, and now it's actually robotic as well. So, like you said, the residents do have to learn 3 different ways and all the pros and cons of each approach. But not only that, they also need to know the pathophysiology and the molecular biology and the administrative side of surgery, as well as the billing and coding, which is also huge.
The computer systems, another
The
big one.
computer system, the EMR. So I mean, the
Yeah.
requirements that these kids have to learn and all the different skills that they have to acquire in 5 years is just astronomically different. Even from when I went and I graduated in 2011.
Yeah.
So
Yeah. I said,
even short like 15 years, it's incredible the amount of stuff, the amount more stuff that the residents now have to learn.
it's really just like society. Things seem to be changing faster than they ever did. In surgery, it's like an accelerating pace of change. Like just talking to Chris Bashan, did a podcast yesterday on robotic surgery, and just in the couple of years that I've been gone from Inspira, they're doing tremendously more robotic surgery, which I kind of thought was not really going to catch on, mostly because of the costs. But he feels that they can keep the costs down, and the big argument he's got is that like if you avoid one open, if you can avoid one open operation where a patient has to get admitted, it balances out the increased costs of the robot.
Yeah, it's a pretty complicated kind of a situation.
Yes.
Because on the one hand, we're doing a lot more operations now, and the patients are much more heavy and much more sicker.
Right.
So if you do an open surgery on somebody, their chance of getting a hernia later on with the comorbidities and expense is just astronomically higher.
Right.
So the minimally invasive is the way to go. And in terms of the cost, at the beginning when Da Vinci first came out with the robot in the late 90s, early 2000, they were the only player in the market, so they could dictate whatever they want to dictate, and the cost was based on anything they called. Nowadays, with the volume, the price is coming down. The surgeons are becoming much more adept and much more economical, and also there's a lot more competition in the market.
Yeah.
So there's other robots coming out. There's single site ports coming out. There's a lot more competition to the Intuitive and what they're doing. So I think they kind of have to cut down their prices and make things a lot more affordable.
Yeah. Also better, talking to him again, he said now you can control your insufflation and everything from the robot. You can teach the residents they have 2, that's always been around. They had 2 two
Console. Yeah.
consoles, yeah, and so the resident could watch. But now you can apparently split up the controls too. So it's almost like when we do laparoscopic surgery or open surgery, when somebody holds a retractor and the other guy cuts, or the other guy, this the one person dissects, the other guy retracts, and vice versa.
The
So
new robotic systems are truly just absolutely incredible.
yeah,
The visualization, the tactile feedback almost, the freedom of motion, the access. I mean, everything is
yeah.
just. And
Is
I
the
remember
lag
just,
gone? The lag better? But
yes.
the lag is good. They've gotten the lag better because
Yep.
that was a problem. And then you said tactile. He said too that they've managed to put some proprioception
A little bit, yeah.
into them. You have a little bit of a feeling of how hard you're pressing,
Yeah.
on something. Yeah,
Yep. And also the arms are much, much smaller. I remember when
yeah,
we first were doing it on the original system, the S model,
yeah,
the arms were huge. They were bumping into each other. It was
yeah,
pretty awful experience. And
yeah.
now the new XI model and even the Da Vinci 5, uh, the ergonomics and the size, I mean, again, it's just eons above whatever we did back in the 10 years ago.
Yeah. Um, like you said, we're doing endocrine surgery. There's not a ton of laparoscopic, except if you end up doing the adrenal, huh?
Yeah, I just recently joined Christiana about a year ago or so, and because it's the biggest hospital system in the state of Delaware, our referral and catchment area is just tremendous. And in the 9, 12 months that I've been there so far, I think I've already done more volume than I've done in 5, 6 years at Inspira, unfortunately. Just
Really?
because
Wow.
yeah, Inspira has so much more competition in terms of the with Philadelphia and North Jersey and Central
Right,
Jersey.
right, right.
So our catchment area in Delaware is tremendous, and then we're the tertiary center for the state. So we get lots of referrals. So I'm definitely looking to start kind of a more of a robotic approach, because of the speed and the safety and exposure and just a more modern approach. Um, and a bit on the personal side, I definitely find that after a tough laparoscopic case, my back is definitely stiffer, my neck is not as
Yeah,
it doesn't feel as good. So from a purely physical, ergonomic sense, laparoscopy is definitely not ideal.
yeah.
Hmm.
You mentioned, you remind me of talking about the fact that I had two partners when we did heart surgery. These were two guys that were almost pure heart surgeons. I was sort of a half heart surgeon, half general surgeon, a half thoracic surgeon. These guys did coronary bypasses, all day long, day in, day out. And they both ended up with, cervical disc problems,
Right.
from, wearing the headlight, which back in those days was heavy.
Yep.
The headlights probably weighed a couple pounds at least, and the glasses, the two or three power loops were heavy, yeah, and
Yeah,
so
yeah.
that was all on your neck, and you were like taking down the mammary and doing the anastomoses and things. You were just holding your neck rigid for so long. And two guys went out with like I say, cervical disc problems. One guy got fixed and came back and worked for another 10 years, and then it acted up again, and he quit after that. you know. But getting back to the surgical residents, the other part of the problem I talked about in the book a little bit is the fact that with more, they've got way more to learn and way less time to learn it because they're very strongly restricted, as we've learned from the American ACGME, General Graduate Medical Education. 80 hours, that's it. And I think surgical residents are probably the only ones that hit that on any kind of or surgical and orthopedic residents. They'd probably be the only guys where it's 80 hours really becomes a big problem. But
Yeah, I think all the subspecialty, the urology, the neurosurgery, especially ortho, us, yeah.
yeah. Medicine, not so much. Family practice, I don't think not so much that 80 hours a week is a big restriction. Yeah. It's
I think for them, transfer of care is a little bit easier.
yeah,
Where, if you and I are stuck in a 7-hour case, like you can't really scrub, but you can't really tap out and
right,
you get
right.
another person in, so you have to finish what you started.
Yeah, yeah.
Yeah, I think also, as you mentioned, the amount of information that the new residents have to retain is astronomically higher than we are. But at the same time, they don't have to. Um, I think their focus is more on the important things.
Yeah.
When you and I learned a lot of other, not
Yeah.
extraneous, but a lot of things that weren't really pertinent to what we do.
Oh, really?
Nowadays, their education is a lot more targeted towards either subspecializing or kind of very, very clinical, very laser focused to what's important in the field.
Yeah.
It's still a
It's
huge
it,
amount of
an awful
information.
lot of what I did in the first and second year of residency was drawing blood, starting IVs,
Right,
and
right,
and crazy things like giving dose, hanging blood. Yeah, they needed a doctor to hang blood.
right.
In 2 o'clock in the morning, you get woken up to hang a unit of blood to giving a dose of digoxin. Nurses weren't allowed to give digoxin. I can't remember. They might not even been allowed to give Lasix, and stuff. So, you'd get woken up and get bothered for all of these things, anticoagulation and everything. But,
Yeah, I think a lot of the non-clinical things get taken away now and gets are done by other specialties, the pharmacists, the nurses, the nurse practitioners, the PAs, the ICU staff. I remember going down as a medical student to radiology, looking at films like you don't need to do that anymore. It doesn't enhance your education.
right.
So I think it's a lot more wheat and less chaff.
Yeah. Yeah.
I
Yeah.
remember
The guy,
spending a ton of
that
time
guy
in the ER
Wapner.
and doing H&Ps and all this other stuff. And while it was important, I don't know if it made me that much of a better surgeon.
Yeah.
Um, and residents nowadays definitely are a lot more focused on what's going to maximize their education and make them better.
On Sundays at Columbia, the intern, if you're on call, you might do 8 H&Ps and draw their blood, or do their EKG on actually literally put on the cups and everything like that, and then read the EKG and read the chest X-ray as like an
Yep.
intern. You know?
Yep.
But it's such so many changes. I was saying the residents have so much more responsibility and so much they get so much more say in things. Like I always joke around about with Dr. DeBakey, the joke was like what he would say, when we want your opinion, we'll give it to you. That's how much they cared about what surgical
Yeah.
and like the pyramid system. 3 or 4 guys, 5 guys would get just 86. Just put out of the residency. There was no discussion. No, it was just the way it worked. Now trying to fire a resident, it takes like an act of Congress, basically to dismiss. You have to have a really good reason, or to do something. But talking about that, we were talking about the residency training programs and how they've evolved and how a couple in our area closed, for one reason or another.
Right.
You were saying it was mostly the residents' feedback, that sort of thing?
I think it was a combination of things. As was with most things, a lot of it is multifactorial. Part of it was the two closures that we were talking about were at Kennedy System and the Crozier System in Pennsylvania. I think both of those, again, were multifactorial. One was the program, both programs were slightly disorganized. I don't know if they had the proper resources to support the resident and education and the teaching, and give the faculty time to teach and devote time to the residents. And because of that, the residents became very dissatisfied. They weren't getting the right education. And with the generational changes in residents, they know what they need. They're not afraid to advocate for themselves. There's a lot of communication between the residents, between each program, with social media and things like that. So they know what the residents in the other programs in the area are getting, and they see that they're not getting the same education. And also the residents have a much clearer idea of their future, and they sort of have a good idea what they will need in their jobs and in the future in their careers and things like that. And they can see pretty clearly that they weren't getting it in those programs.
Yeah,
And when they voice their concerns, nowadays you have a lot of ability for the residents to voice their concerns to the program leadership as well as ACGME and RRC and the national organizations.
yeah,
And they voiced their concern to the program leadership, which unfortunately either chose not to or couldn't address them or couldn't fix those things.
yeah,
And it just kind of went back and forth and eventually escalated to the national organizations. And then unfortunately with Crozier, you had private equity that
yeah,
came in and just decimated Crozier, which is just,
yeah.
and that's a whole different discussion, the private equity and what it's doing to the American healthcare. It's just completely predatory and atrocious and just borderline illegal.
Yeah,
And that's
within the last,
awful.
month, I've probably seen two or three articles in general magazines, not even scientific. I have probably a couple in Scientific and a couple in Epoch Times and the New York Times and newspapers that I read, talking about, this is one place where you might want to, keep private equity out,
Yeah.
because it can't be all about profit. You know what I mean?
Yeah, we're getting a little off topic, but I mean,
Yeah.
it's pure capitalism, and
Yeah.
unfortunately, medicine and pure capitalism don't mix very
It's
well.
good for some things, but it's not so hot for medicine because we
Right,
do so much work for free, and
right,
it's necessary. I mean, it just the way it always has been,
right.
and the way it's pretty much got to be. I don't see to be able to fix that.
Yeah,
Uh,
and I think
in,
it has to change at the national level, at the federal level, on the legal side, because unfortunately, these private equity firms then will not police themselves.
yeah,
There's no conscience involved. There's no sense of right or wrong or ethics of any sort. They're just making money,
yeah.
regardless of who they hurt.
Well,
So,
their dues, they feel
anyway,
their duty is to the shareholders,
correct,
basically, rather than to any higher authority. And that's just, I mean, that's okay. That's capitalism that works well in an awful lot of places.
right.
But medicine may be one place where it's not so high, especially for training programs, which are not necessarily super efficient. I mean, this is, I'm sure you've been involved in situations. I've been definitely involved in situations where you let residents do cases. Dr. Cooley used to say that a few people had to die to train a cardiac surgical resident. So
That's pretty
residency
awful, but
training in
I can
particular
see
is
that.
not. I mean, I think it's great. I think it really has advantages, but it does have some disadvantages. And especially like in July and August. That's like everyone says, that's the worst time to get sick.
Yeah, I think that's used to be the case when there
Yeah.
was where there was almost no supervision or very minimal supervision.
Yeah.
Probably in the last like 10, 15 years, especially July and August and in the beginning of the academic year, the senior residents and attendings are so hyper aware of
Yeah.
that. Then there's
Yeah.
so much supervision for the juniors
Yeah.
and interns that I don't know if it's true anymore. I think it's even safer because there's so much extra supervision, so many eyes on what's going on, and every single thing is so supervised.
Right.
But I think in the past it was because there was a lot less supervision.
Yeah. Yeah. Like I said, we would keep the residents, the call system. You didn't kind of move up to the next level of call right away in July and August. You keep the more senior residents still taking more call for those first couple of months it's amazing how fast the residents do assimilate though, and how fast they do gain knowledge,
Yeah, and that kind of and that dovetails into what we were talking about earlier, how we kind of have a better idea of what works and what doesn't work, and what the residents need to know and how they learn better.
yeah,
So because of that, I think their ability to absorb information and get better is so much faster and so much better than even what we had. So these residents progress much, much faster.
yeah,
And
yeah,
I think they also come in with much better critical thinking. Because I don't know if that was emphasized when you and I were coming up, but
yeah,
now they're taught much more critical thinking and research and how to analyze problems and solve problems
yeah.
rather than just memorizing the Krebs cycle.
Right, exactly, right. Yeah, yeah.
And they can adapt much better than a lot of other people 10, 15 years ago.
The other thing that's a huge change for me and probably somewhat for you is how many the females. It used to be there were almost no female
Right.
surgical. I knew a one or two, like
Mhm.
and then the number has like steadily increased. But now it's probably I know in medical school when I was started again in Dartmouth in '69, yeah, there was 50 males in the class and 5 females. Now, my understanding is that nationally, you're talking about like a little bit more females than males, actually. It's pretty close to 50-50, but I think a slight edge for
Yeah.
women. And,
Yeah,
we
in medical school, it's a little over 50% females.
yeah. And we got, in a surgical residency with our program in Spirit, we had probably more than 50% females, I would say. And
Yes.
again, in the beginning, I was a little, reticent about it, a little worried about that, but I found that they really do a great job. And, big thing, old thing used to be like somebody had big hands. They'd say, well, he's got big hands, he'll be a good surgeon. The reality is small hands will probably make you a better surgeon.
Yes.
And now with the robot and laparoscopic, the size of your hands doesn't even matter all that much at
Yep.
all. Yeah. Well, anyway, I don't think we're going to get to endocrine surgery today.
No.
Yeah. Anything else you want to throw in, talk about with the residency programs or anything you think of?
Yeah, I mean, I guess what you mentioned about the females and the males. I think nowadays the emphasis is almost non-existent gender. It's almost fully based on how good of a physician you're going to be. And I
Right.
think it's really, really nice that we're getting a lot more people. And female, male, it didn't really matter. Everyone that we had and I've interacted with were, for the most part, amazing surgeons and really driven, ambitious, very educated people.
Yeah.
And there were definitely considerations for females versus males. Obviously, if you have a 6'5" male with 8.5 gloves,
Yeah.
there you're gonna need to adjust different things for him versus a
Yeah.
female
Yeah.
who's
You should go to ortho.
5'9".
Yeah.
Right.
Because
Just,
you got to be strong as an ox and twice as smart.
right, right. I remember one of the female residents said that, when she was firing the stapler, she had trouble kind of reaching across
Yeah.
to kind of fire because her hands were much
Yeah.
smaller than, a male. And unfortunately, at that point, didn't have a good solution because unfortunately, the staplers in the device are made for like an average size male, which
Right.
they were.
And right-handed too, mostly.
And right-handed too, correct.
Right.
But nowadays, it's really not an issue anymore between the genders. And I think it's incredible that the females going in are not only allowed, but encouraged to actually pursue their passions, their life, have children, and all these other things during residency and training. Because before, you almost had to put your life on hold.
Yeah.
And nowadays, males, females, it doesn't really matter. If you want to start a family, it's definitely tremendously encouraged during the training program, and it's really not that big of a deal.
Yeah, I'm told they didn't have any rules when I was a resident. You were allowed to be married, but very few guys were married even back then. And I'm told, I mean, I've seen TV shows and things where from the 60s, 10 years before me, basically, and the residents were not allowed to be. It was a Mad Men or something like that.
Mm-hmm.
One of the girl in Mad Men ended up going out with a surgical resident, and in like a Cornell or someplace, and he wasn't allowed to be married. In the 60s. Yeah.
Yeah, that's completely not the case anymore.
Yeah.
What you mentioned about Halstead, where, when it started, it was so hyper patient focused that the physician was pretty much an appendage and really nobody cared what happened to you. And, all the personal health and mental health and all that stuff that really was a non-existent issue. Nowadays, it's still incredibly patient focused, but we're definitely not ignoring the physician, especially the surgeons as well.
Yeah.
So there's definitely a lot more focus on that.
Yeah, a lot more focus on avoiding burnout. And like you said, the robot is a big speaking of surgery, that's one of the things that's often touted as an advantage to the robot, that you're sitting and you're much more relaxed. You can work a lot longer, than when we used to stand for, 8, 10, 12 hours.
Yeah.
Anyway, I think that should do it, Leon.
Okay.
Thank you very much.
Sounds great. Thank you, Charlie. Have a good one.
Okay. We'll say goodbye. It's the Make America Healthy Again podcast. And we'll be back in the next couple of weeks with another talk to a resident talking about one of those programs that closed. See you, Leon.
Take care.
Bye-bye.